Welcome back. This session is called Streamlined PFA Workflow for AF Ablation. And to best illustrate this, we have another live case, this time from Christian Sohns and his team at the Heart and Diabetes Center, Bad Oeynhausen, Germany. Sorry for the terrible pronunciation. Let's first meet our panel for the session. Devi Nair returns, but we also welcome Kousik Krishnan from Naperville, US, and Alexandra Almarad from Brussels, Belgium. Remember, keep submitting your questions and remember to claim your CME certificates for the program. Simply click the button on the web page and add in your details. So over to you, Christian, and your team. What have you got for us? I think we've not got audio from the lab at the moment.
Ich kann nichts mehr hören.
Here we go.
So I think you can hear me. I hope you hear me. I'm not sure. Good evening, first of all, from Bad Oeynhausen, Germany. Maybe Bad Oeynhausen is the most difficult part to pronounce it correctly, but it's possible. It's kind of a night session today. And therefore, first of all, thank you to the team which is here. I would like to introduce Tatjana, Peter, Jana, Betül, who will help us with the case, Dr. Kalaf, Dr. Tchaikovska, Abdullah Ertem. So a lot of people are still here around. And of course, we would like to say thank you to the patient who gave us the consent to do this live case here with the Varipulse device today. Before we start the case, Dr. Tchaikovska will give us a short introduction about the patient and his individual AFib history. Frau Tchaikovska, please take over.
Yeah, hello. So today we have a 57-year-old patient with paroxysmal atrial fibrillation. The disease is known since 2020. Otherwise, his medical history is unremarkable. He's highly symptomatic during the AFib episodes, complaining of palpitations and shortness of breath. His echocardiogram showed normal heart function, normal heart dimensions, and his CT scan showed normal PD anatomy.
Yeah, I think this is very important information. All patients here receive a pre-procedural imaging. In the majority of cases, it's CT. In this case, it was MRI. And from this, we have the information at least that we have 4 separate pulmonary veins, which so far is then an ideal candidate for ablation. So let's start with the procedure. Dr. Kalaf and me, we will start. You see that there is a CS catheter in place for giving us orientation for the transeptal puncture. And we have performed this already. Dr. Kalaf, please show us some information about the transeptal approach. You can see that we used the Visigo sheet for performing the transeptal puncture. You see there is a clear drop here in LRO projection. We have no eyes or echocardiography or anything else around us. You just look for the jump and we go to the next image. And then you see that we checked RIO and LRO projection and then finally performed the puncture under pressure measurement and also using the wire here to go to the left atrium. Let's start with the procedure itself. You see that we have already the catheter in place. And the first step, and this is very unique for this catheter, is that we can calibrate the TPI to be sure that we have a good catheter to tissue contact. You see that here is calibration going on. The first electrodes are already yellow, and we advance them now very slowly. This go to LRO projection, very slowly to the atrium. You can also see that the electrograms, they start, and we can then have all the 10 electrodes finally with a good TPI here in place. And the next step, that then also comes visualization of the Visigo sheet, and we will then now start performing mapping. Please give us some information. You can also see that the catheter is ongoing, collecting data. We have PA left lateral projection first. You can clearly see that we are collecting a lot of plots, and the green color shows us that we have a good TPI in this situation, that we have good contact, and only in good contact we collect points. You can also see when we have a look at the electrograms just for a second how good the quality is in terms of giving us information about the myocardial amplitudes, and you can see that then we can advance the catheter towards the veins, which is always important, taken into consideration the catheter design. Here is now the left superior vein. You can see some delayed signals here already if we see that. So this is one of the veins, and we know the patient has 4 separate veins. So we now check for the left inferior vein as a next step, which is a little bit posterior in this patient. We continue collecting anatomy just for a second. And you see that it is a more or less healthy atrium so far. Going now to the right superior vein. Please go to RIO, Dr. Kalaf. Oops, we dropped the catheter.
Christian, can you just quickly explain the contact and the calibration again to us, please?
Yeah. You can see it now at this time. The catheter is now more or less in a vein position, even if it's not a good one at this time. I agree, and we don't have the anatomy, but you can clearly see these bubbles, and these bubbles, they show us that we have a good TPI measurement at this time. If Mr. Erdem can show us the bullseye here in the middle, you can even see this a little bit nicer projected, so that we can finally use this TPI in terms of lesion application on the one hand. And you will also see that this TPI measurements then correlates a kind of a grid cloud, which allows you to understand that good TPI finally then results in a nice, straightforward lesion. And while we do so, I can also give you the information from the data we have, that is MRI data, that when you finally have good TPI, then you also see lesion formation in the MRIs of the patients 3 months after ablation. So this is really a good measurement tool. I think, just for a second, Mr. Erdem, please go to the map we already created to give you a nicer overview and not to waste too much time. But was this already the answer to your question in terms of TPI, Richard?
Yeah, and so the calibration is the difference between the sheath and the blood pool is how you calibrate initially. Is that right?
That's right, yeah. So you saw at the very beginning the catheter was inside the sheath and there was all electrodes black. And it's like a self-learning process, which took time in the previous version. But now you finally can say, when you go out of the sheath, then you see ongoing calibration, and it's just a couple of seconds finally to have a nice map in these patients nowadays. So another thing which is very important before we start with the ablation is that we need to take a clear look at the ACT. For us, I mean, we are German, okay, we are always very strict, but it's very important to stick also to the standards in terms of ACT measurements. And we have an ACT of higher than 300s, and that finally allows us now to generally start with the ablation procedure. Before we do so, and this is what my colleague already said, we give the patient some atropine and some fentanyl, which we are doing now. So this is more or less our approach. It's also important to mention, when you look at the patient here, you see, and there is no anesthesiologist around. We have a nurse-administered protocol. Tatiana is running around here, and she is taking care more or less for analgesia of the patient. And I think it's also interesting to see for you in a couple of minutes that when we give these applications, then you can see that the patient is normally not moving a lot, not coughing a lot. So performing this without general anesthesia works quite good in all the cases. And we have now performed more than 150 cases or even 200 cases with a Varipulse device and without any problems following this approach. Any other experience from the panel and or you, Richard?
Kousik, do you have experience of this?
Yeah, we generally use general anesthesia, so I'm very curious and interested. Like, what is your protocol for? Like, do you tend to use propofol, or do you use Versed, fentanyl? What is your protocol to be able to perform these so well without general anesthesia?
Yeah, at the very beginning, we give the patient some Dormicum, some midazolam, together with a bolus injection of propofol, which is wide adjusted. And after this bolus injection, then we keep with an infusion of propofol during the procedure, and you will see this works quite good. In addition, prior to ablation. We don't know if it helps or not. We give the patient some fentanyl to avoid any pain. And this is more or less what we're doing. Why we discuss is exactly the time we have now from the fentanyl injection and also to giving the atropine. You will also see this our experience. I think Alex is also there. Giving atropine helps us not needing right ventricular pacing or something like that. It works straight, very good. And we're happy with this approach so far. So if there are no more questions from your side, you know more or less using Varipulse normally requires 4 applications per vein, 2 applications a little bit more distal and 2 applications more or less in the ostial area. You can clearly see when we look back at the TPI here once again that we have now nice bubbles everywhere, having also a smaller cycle now of the catheter. We once again check that ACT is correct. We have good sedation of this patient, and this is then the place where we would give the first application. And while we're doing so before we start, please now highlight the electrograms, giving you again the opportunity to see that the signals finally disappear. And Mr. Ertem, now please here give the first application. Now it's loading, you see, and look at the patient. The patient is not moving at all. You see that the main component of the signal already disappeared. We have 3 cycles. That was number 2. And you can also see that around the area where we ablated is now we call it a grid cloud, which shows you good TPI and good coverage of the patient. While we now see the patient a bit coughing, we also have now the possibility to see where already a good TPI was achieved with ablation, which is then highlighted in green color. And on the other hand, you see that there is sometimes red color, which shows you, let's say, potential gaps or let's say areas where no good TPI was achieved. So we can still a little bit rotate the catheter, which is also useful to take into account the catheter design. We go now a little bit more osteo. Please also show us the bubbles, Mr. Ertem, and then if it's okay so far, we will then conduct the next application here in this area. So please start, and please put the bullseye in the middle. So also, if you see the patient was coughing once again, we have no alert in terms of map shifts or whatever, which is also important. The catheter moves a little bit while we give pulse field ablation, but this is common more or less, taking into account all the systems which are available. And then you see more or less in the distal part of the vein, we see already some scar formation, and then we go outside the vein to also cover the ostial area a little bit more. So which is now such a position. You see green shows us, and it is clear also for everyone out there that green has no scar so far. So this should be something we can now again target. I don't know, maybe we can highlight the bubbles once again, Herr Ertem, which would be helpful. But we need some catheter visualization anyway. You see that green requires ablation, and we see nice signals. So please go on with the next application so far. And you see we always work in 2 angulations. On the left side, you see posterior anterior view, but on the right side, you also see that we have a view where we are in terms of the carina area. It's very important also to also cover this place, and therefore we always work into 2 angulations, and that's straightforward. So that was so far the next application, and again, we will now rotate the catheter a little bit more. I'm used to have wide circumferential ablation, also using single tip catheter ablation. This is why we also opt for an ostial lesion. You can see that we are switching out of the vein here immediately at this place. So I think we can give one more application here in this area. Mr. Ertem, please start. You can give us the next application. Then we have these 4 applications. We always stick to the standard. We just in time that we do see some gap formation during repeat mapping, then we give additional lesions. We can discuss about that later on. I think you all have your impressions with that. But so far we have now 4 applications. When we go back to the very first signal. You see that the signal disappeared, and we will now use the steerable sheet to go into the inferior vein and continue the ablation sequence right there. When we can.
And just a reminder, like
allow.
the second application, the rotation is to kind of cover up the lack of energy being delivered between electrode 1 and electrode 10, which gives a gap. And
That's right.
So that's what you're doing, correct? The rotation is to allow for energy delivery in that gap.
That's it. Exactly. That's it. Yeah. Yeah. And now we see the bubbles came back, which is helpful for us. And we will now, you see now, when we are too deep in the vein, we still see the signals, no more signals already, but we will now try to get to a more ostial position. We open the catheter a little bit more. You can see this now in the Cato system. And then we will pull back until we see an ostial signal somewhere. Here are some beautiful, look at the signals here, and that's a good place for the next application. And then you see that after this application, please now go back to the electrograms or show us on the offline screen. And please show us in 100 speed that the signal disappeared already after the first application. That was really a nice example. But anyway, again, as Richard said, we will rotate the catheter, we will close the gaps. And again, the color coding will definitely help us with that. And the catheter comes back. We see red shows us here was already a good place for ablation. So we need to angulate the catheter a little bit. Now here comes more green, but we are dropping out. Now, the inferior veins are sometimes a bit tricky. I don't know what your experience is. We will manage it somehow. Now we dropped off to the right-sided veins. Okay. So here is a good place for next application, please. You can again see when we go back to the signals that there was still a tiny signal here in this rich area. Please go back to the review screen for Tchaikovsky and show us this smaller signal. And we need to highlight. Here you see that there's still a very pulse 7/8. Something, a 7/8 is exactly, when you look at the right Cato picture, is exactly where the ostial area is expected. So yeah, that is very helpful. Now we open the catheter circuit a little bit. You see that we're still inside the vein. The vein goes a bit posterior, so it's a little bit tricky to go to the ostial area here, but that's okay. Good TPI. Next application here. And when you look at the right side, you can again see that in this posterior orientation, we have very good TPI. Whereas the TPI, I would say it's limited. Electrode 10, 9, and 8. You can also deactivate them, but 10 has now good TPI. So yeah, it's always a question of the TPI. And when we try to normally get 12 out of 12 if it's possible. So the last application now I will try to come from the posterior wall to this area, because there's still a smaller space, I would say, where we can give one more additional application. We have seen with the first application that the vein is already isolated anyway. And we can use the steerable sheet a little bit to go with this posterior. Here's good. You see that we're now aiming to get this last tiny bit ablate. And then we will check afterwards whether this area is then entirely ablated. And you see, I think now this is the first time I look to the watch or to the clock. So now we have 20 minutes for mapping and isolation of the left-sided veins. So we have another couple of minutes, which shows us again how fast these procedures finally work. I mean, at the beginning we said the coffee is still warm after the procedure, but for us it's a little bit too late for a coffee. We move to the right veins. That was a very clear and easy move. We can also now check the fluoroscopy. Maybe we can highlight this just for a second. We have the fluoroscopy. We push a little bit more forward. You see that we're getting better TPI now. 6 is not 100%. Therefore, I will now open the catheter a little bit to get more tissue contact. We will try to ablate here, but you can already see now in the bullseye there is an overlap between electrode 1, 2, and 10. So let's see whether the system will allow us ablate here, but it can be that it will stop and not ablate. We will see. And it works. So that's good for us, the patient. please show us once again how the signals were eliminated for Tchaikovsky, and therefore highlight the offline screen. Again, you can see loading. A couple of seconds later, ablation, and the signal disappeared. Now, therefore, I like the catheter because we have always a lot of applications. We see the disappearance of the signals many times. I'm quite sure you also like it. And then we rotate the catheter once again. You can clearly see it when we look at the bubbles. You see in this case, we go clockwise. We go a little bit more ostial. Ostial gets now green, and there we ablate once again, Herr Atem. And while we ablating, we also check the position into RIO view. Please go to RIO view to be sure that we really have a nice placement here. And you can again see that also into this angulation, we have a very nice, let's say, coverage of the ostial area for the right inferior vein, which is also, I think, always important to switch around between the views to be really sure that we achieved all the important areas. We open the catheter once again to cover also some pieces of the maybe posterior parts. Again, you see the majority is now red and we are dropping out. So we need to replace the catheter here once again, going into this area and opening it once again. Everything is red, so the system suggests us not to continue ablation, but now here's some green spots. Please ablate here and go back to RIO position. RIO, Herr Atem. Yeah. So the catheter is now more or less exactly there where the carina is. And we see also some spaces here already projected to the superior vein. Go back to PA. Oh, we drop off. Stop. So whenever we stop, we repeat the procedure. So we go here once again. There's more green. And please ablate again, Herr Atem. Because, it's our fourth application here. And we need to do one more application. Look again, please, at the electrodes, and Herr Atem, yeah, he said it's overlapping, and therefore look now at the bullseye. He deactivated electrode 1 and 10, and I hope that now we can ablate. We cannot, but we will open the catheter a bit more. Okay, try again. Now it works.
Remind us of what the problem is with an overlapping electrode.
Yeah, it's more or less, to give you a good physical background is not so easy, but when these electrodes are too close to each other, and we know this, for example, from PFA applications, then the electric field is maybe too strong and can then also result into harm. We also know that PFA lesions get deeper and deeper when they get over and over each other, and therefore the system is not allowing us to perform these applications when these electrodes are too close to each other. So now we have these 4 applications here. We go now to the superior vein, which is then already our last vein. Unfortunately, it makes fun, but he has only 4 veins. We see here again the signal. We try to open the catheter once again. It's always the same. We have good TPI now, looking at the bullseye and all electrodes. So here's first application, please. And while we ablate, we go to RIO projection once again. You see that there's still some space to pull the catheter a little bit back, keeping in mind that we have always 2 applications more or less in the vein and 2 out of the vein in the ostial area. So it's already isolated, but there's still some work in terms of lesion formation to do. We rotate the catheter once again. Please go to PA view now. Herr Atem, please go to PA view. So you see that we try to get more to the ostial area now, posterior wall. Here it's green, ablate, please. It was very nice to see the change from red to green color. So once again, keeping in mind, red means there is already a good TPI, there is already a good lesion, and green shows us ablate. And this is what we're doing. Second application so far, which means we only have 2 applications left. But I think we're more or less good in time. And it shows us really that we can do these live cases within.
The audience is asking, why does the
Is there a question?
need irrigation?
Why is it? Please repeat. Why is it?
Why does this catheter need irrigation, unlike some other PFA solutions?
Oh, this is something we need to discuss. We use irrigation, but we know that there are different irrigation programs. We have only 4 milliliters per minute, whereas our colleagues from the US, and you will definitely comment on that, they use 30 milliliters per minute. There seems to be a thermal effect also in pulse field ablation, and different systems have different thermal effects. And I think it's something we will get the answer not today, but in the future, whether more irrigation is helpful, yes or no. If you ask me, from my personal perspective, we have not observed any complications in terms of irrigation, more or less. And I also think what makes this technology so interesting is doing ablation into even also complex patients, heart failure patients, where we see a lot of them. And there we also use pulse field ablation, and their lower irrigation is, on the other hand, beneficial for them. So why it is kind of the technology, how much, is something we can discuss in a few minutes. Yeah, next application, please. Oh, this is more or less the third one, and then there's only one more application, and then it's gone. But what are your experiences with that? I mean, we have also colleagues there from the US, and Alex is there, and Richard, you also use this device. Do you change the irrigation between the procedure with him, or did you stick to the 4 milliliters per minute?
I have used it. Kousik, do you use this technology?
Yeah.
Yes. Yeah, we started using the 30 cc flow rate really from the very early on. And, there was some data that Will Sauer, published around HRS about kind of the joule heating, the potential, it's generate 1800 volts over 250 milliseconds. So there's potential for some joule heating from any catheter that's delivering that kind of energy. It's not unique to this system, and that the temperature on the electrodes potentially could be kept lower with a higher flow rate. Right now the system is not automated for that 30 cc flow rate. So when we come on ablation, we have to manually turn it to 30 cc's every time we come on, and then when the ablation is over, that series of 3 applications are completed. Then we go back to 4, and I guess it just from a physics standpoint seemed like it was had some good reasoning for it. We haven't had any complications at the 30 either. Even if you're giving 16, 18, 20 applications and you're only giving that 30 cc flow rate for about a minute, it's not a tremendous amount of fluid load unless someone, certainly if they're very fragile heart failure patients. So I think you could probably get by with either one. Certainly, Krishnan, your experience seems to, have a lot of experience with a catheter with 4 cc's with very good safety margins. So I think that in the United States, the 30 cc flow rate was recently FDA approved as on label. So it was kind of off label before that.
And Devi, what's your experience of this?
Yeah.
I'm deliberately slowing you up, Krishnan. You're too quick.
As well.
Yeah, it's good. It's good. We're just doing remap. Yeah.
So I would agree with Kousik. I think we did a large number of cases with the 4cc workflow. It did not have a lot of issues, but we would actually watch the impedance on the electrodes, and we'll actually see sometimes the impedance changes corresponding to maybe char, etc. So the 30cc workflow has worked very well for us too. And like Kousik said, even if you do 20 to 24 applications, which is what we end up using for a PVI posterior wall workflow, there's not a lot of fluid, and it kind of, I think and we've not seen any issues with durability. So I think the catheter does well with that flow, and except for the fact that we have to go and turn it on every time, I don't think that's as big of a deal, which I think it's going to become automated I might be, getting too ahead of the curve, but I think it is going to get automated. Krishnan, I do have a question about, you kind of very masterfully got this catheter within the pulmonary vein and got really good osteal positioning. We're starting to see more and more PFA systems come that sometimes don't address or don't go inside the ostium, like we just saw a Volt case, we see cardium, that just sit enterally. How important is it to get this catheter deep into the ostium? And what if the veins are small and, it is a little bit stiffer catheter? Sometimes it's not easy. What are your thoughts on just having very good antral lesions? Is that good enough?
I think it's very important to have antral lesions. I mean, when we look now, and please show us TPI and the correlation between the low voltage area, I think it's very important to still have osteal lesions. I mean, we know that we can create lesions everywhere. We discussed this already, posterior wall, whatever. But I think from this point of view, I mean, good catheter to tissue contact is still very important. Also to place also in terms of avoiding hemolysis, for example. And I do not have 100% idea of the ideal catheter design. So we also have experiences with lattice tip, large footprint, and so on. But at least you can see for the target pulmonary veins, this catheter seems to be very good and ideal, even though it was not so super easy to go to the left inferior to the left inferior pulmonary vein. Sometimes also the right inferior vein is difficult to achieve. We still need improvements, but I think for the pulmonary vein isolation, it's an ideal design.
And I noticed that also on the map, you're using CARTO to automatically tag. And I'm skeptical about these systems' ability to reliably mark electrograms because it's showing voltage on the posterior superior aspect of the vein. But I think that when we went and looked at the signals, there weren't any signals there. Should we be as reliant on these systems?
Yeah. I don't believe in any system. I don't rely on any system, as you do so as well. And I'm also a bit disappointed that we cannot really have a 100% fit between voltage here and also the information from ablation. But what we did in this case then was doing exit block pacing here in this case, and we have no capture. So this area is isolated. Maybe it's a far field area from the appendage or somewhere else, but it should be a little bit better. Yeah, you're right. I agree. This is why even whatever color it shows you, you still need to go to the place and pace.
It's good to know that we're still better.
Do you ever do isopropyl testing? Sorry.
No, we don't do it.
So I want to ask
anyone else? I mean, we can discuss it. Yeah.
I want to ask you and the panel. So what we're seeing now with PFA is that you're not getting a neat circular lesion because often you're ablating within the veins, you're coming back, you're doing ablation proximally as well. So you're doing multiple applications at multiple levels rather than the single ring of cryo or wide encirclement. So when we get reconnection and we remap these patients, to my mind, the signals are much harder to interpret because you can't easily see the point of fragility where the vein is reconnected. So how do Kousik, how do you deal with the remapping and re-isolation of the veins? Do you just go around the whole vein again, or can you track where the break is, or what's your approach here?
So I mean, I always check the osteal area first of all. Whenever I do a repeat procedure, also with a ref, we look where is the pulmonary vein osteum. We try to mark it. Therefore, we use imaging in the majority of cases. But if we now find a reconnected vein after these first four applications, we always indeed give another 4 applications, not giving just one and see that maybe due to stunning or whatever reason, we see no signal because we don't know how this atrium will look like tomorrow. And therefore, we give another 4 applications because we have something like, let's say, evidence here from animal models. And other important thing is, and this is something we see from MRIs, we do always like the research about MRI in these patients. And what we learned is that we also see different lesion formation using the different PFA technologies. And we see so far using this circular catheter more or less a lesion formation which is comparable to those we see with a single tip catheter, whereas when we use the pentaspline or whatever, where we have more or less an area that is covered, there we see some smaller areas of reconnection, which look more or less like a BT channel, which is different here. So it's not clear. We need more data, but as long as we don't have it, we do another complete for applications or how it is ever recommended by the manufacturer of the PFA device.
But Christian, I'm really talking more about patients you've brought back because they've had a recurrence and you're having to redo the procedure. So bringing them back on another day, what's your approach then to?
Yeah, so you mean what we saw within repeat procedures after PFA?
Yeah.
Yeah. In the majority of cases, we still isolated veins, which is very bad. Yeah, but this is the problem. I mean, on the one hand, it's good that we see good lesion formation, but in general, these are just some smaller osteal spots. So yeah, we improved. I think we all improved in terms of lesion formation from using PFA. Smaller gaps, but bigger problems. Because just when you look at this patient, for example, and this is something we can also discuss, you look at his posterior wall, it's super healthy. Others would say, we have a PFA device now and isolated veins, so we do the posterior wall, it's still difficult. Our approach is always that we do voltage mapping. And based on this observation from voltage mapping, we look at the gaps, we re-isolate the vein if there is a gap. And if there's something else, we target this as well. Yeah.
Kousik, what's
The
your
amount,
in this
it's
scenario?
something I can just speculate, but we have data, for example, from very pure secure study and so on. We're looking forward to this. We have the impression that after we perform ablation now with PFA in these patients, the recurrence rate seems to be lower. If this is true or not, I cannot tell you today. But I think it is lower, and it is maybe related due to the fact that we take off the PV-dependent AFib patients, and the reminders are those who have substrates, who might then need additional imaging, and who might need additional lesions with additional catheters. I think this is maybe something we can discuss.
Kousik, what's your approach in this redo?
You were part of the real world data,
yes.
right? In the US?
Yes. Yeah, the real AF study. So, we get to cheat a little bit in the United States. We use a lot of high density mapping catheters. And so I've actually only had one varipulse redo and the veins were still isolated. So some of the experience that we had early on, what I would say is we will sometimes use the catheter, even in this case, you had this technique where sometimes that some of the electrodes are not making full contact, but you're favoring the fact that there's a particular location of the atrium that you need good contact on, and you're making sure you have contact in that area, and you still ablate even if it's not circumferentially all 10 electrodes. So when we first started using this catheter and we did a lot of high density mapping pre and post, we found that there were certain locations, just like when we did cryo remaps, we kind of know where the reconnections tended to be with cryo. They kind of occurred in very similar locations. So now we will often target, like on the left side, the posterior carina with an extra lesion. The upper part of the left upper is another area, either with ice or with an extra lesion, to make sure that we have good coverage there. But for us, when we have the veins isolated, we tend to do the posterior wall, and we're now actually doing a fair amount, again, off-label, of superior vena cava isolation. We'll map the sinus node with high-density mapping, and the catheter is very efficient and well-suited for SVC isolation without what we have to worry about with RF, sometimes not being able to ablate circumferentially because we're close to the phrenic nerve. So that would be our approach for someone where we have PVs that are isolated but still have recurrent AFib.
And Devi?
I mean, I tend to, I have to say that the redo population with this, the PVs usually are pretty isolated. We're using the contact assessment with the TPI, but also eyes to look at contact. So it's almost like double validation of contact. And I have to say that once you have, if you make every lesion count, that's like my theory about this, is not to apply the energy until you know for sure that that lesion is going to be good. I think you get a pretty good, durable PVI isolation, even chronically. I have to say that when we come back, they usually match. There's not usually a spread of the voltage, and it kind of is contained within where we did the ablation. I don't see a lot of bleed through with the catheter for sure. So like this map that Christian's got, I mean, it shows very good voltage posteriorly. So I would feel very comfortable leaving that posterior wall behind, not touching it, and take the kind of minimalistic approach of just PVI only. But if I do see that it is a very narrow channel, or if I see that the voltage is bad, then I don't hesitate in taking that posterior wall out. And regarding your repeat ablation, I have to say that I go and clean it up if I see borders that look shaggy. I guess I would say that, but it's not very common that we have to do that at all.
Yeah, I mean, something we can just show you once again, maybe here also fill color threshold, and then we have a nice overview about pre and post ablation images. Please fill color threshold, and then you can clearly see that we have now achieved this. And you see, I mean, there are 3 points which are not correctly annotated, but it doesn't matter. But you can still see that there is a huge distance, and I would not go for additional ablation in this patient. I mean, even if you go and now rotate to RIO, please. I mean, RIO is nothing, and everything looks very healthy. So from this point of view, I think this patient is now treated so far. Go back to PA, please. And there's no need for additional ablation. If he comes back, we check the veins. If the veins are reconnected, we re-isolate them. And but I mean, just think back to the era of radio frequency ablation, for example. Such a patient will not receive a posterior wall isolation with RF, but maybe with PF. So yeah, this is also something which changed our thinking about ablation procedures itself.
Christian, we're being asked by the audience, why is there a 10-second pause between the pulses?
Was it a question to me? Then please repeat it.
Yeah, so the audience asking, why is there a 10-second pause between the RF pulses, the PF pulses?
Yeah. So different reasons for that. One is recharging. The other one is, let's say, waiting so that not a too high temperature rise is achieved. We discussed this already with lesion formation. So this seems to be an ideal sequence, avoiding collateral damage and also giving the system time to recharge.
And have any of you experienced phrenic nerve damage associated with this technology?
I have not.
So, yeah, we have not observed it so far, no. So, but I mean, there could be some. If we discuss indeed vena cava superior isolation or something like that, we need to be aware of that. But we have not observed such a problem. We have also not observed it performing other procedures in the ventricle, for example, using other devices. So it's something we have not yet seen. And we have also, fortunately, not seen any stroke or tear event. And when Alex can maybe also just report a little bit from very pure that we have not seen any severe complications in these patients.
Yeah, we certainly, in the first cases that we had at Barts, there were some, and I think in the UK, there were some neurological events and a lot of smoke appearing on the TOE. And I think it was an electrode design problem. I don't think that's been a problem in the US, has it, Devi? Or
no, the real AF, real
small
world
indication. Yeah.
Go ahead.
Go ahead, Kousik.
No, I'm talking
saying
more of
the-
in the post-market, the real AF data showed less than 1, like a 0.8% neurologic event rate. And even that one event that was reported was possibly a ocular migraine. So, it was either one event out of, a 0.8% or zero.
I think the key, Richard, is what Christian did is about getting that ACT appropriately high enough before starting the application, and I think those are the key factors to me, making sure there's contact. There is that microbubble that we see on TO, T as well as ICE images, but I think that is not very unique to this catheter. I think there's something we see with every pulse field catheter. There definitely was there was a slight concern in the beginning, but I do believe that everybody was going for a single transeptal straight with the Visigo. You're in the left atrium before you know it. You're getting ready to apply because you're using the same catheter to map and ablate. So you get to the atrium quick. You're ready to ablate quick. I don't think many of us waited long enough to get that ACT high enough. And I think we learned it the hard way, is what I would say.
One other point is maybe also, I don't know how you started with these procedures. We always started with a two-catheter approach. That means we used the pentaray or octaray to do reconstruction of the atrium, also from a research point of view to compare anatomy building and so on. And every change of the catheter during the sheath can also, let's say, make some of these problems. That was also the fact when we started with a Farina catheter. So now it's a single catheter approach, no more changes, and everything you can take out of this problematic road is at least the benefit for the procedure.
And is this a technology that will allow you to send the patient home the same day, or do you hang on to them overnight, or how do you manage the patient post-op?
We in Germany, we have huge discussions because we until the end of the year we will do these patients without same-day discharge, but we will change as 1st of January with that. As you see here in the groin, we have punctured both groins. We will do a set suture afterwards, but we can also just go for one groin. So I think indeed, so when you have such a patient, I mean, he's young, he has no comorbidities, he lives next street of the hospital, which are also factors which enables us to let them go home the same day. This is an ideal candidate for that. So I think, so also with PFA technologies, having a single catheter approach makes it for us easier, whereas I know that you do same-day discharge already since years.
I think there's an insurer issue in Germany that's now being resolved, isn't it? Which is why you haven't really done it. Kousik, do you same-day discharge?
Yeah, I would say more than 90% are same-day discharge. We generally do 3 accesses, but on the same side, since we use intracardiac echo, a lot of vascular closure, either Vascade or Perclose, and 2 hours ambulation or less, and like more than 90% go home the same day.
And I know that's true in your case as well, Devi.
For us too. Yeah, I mean, we're doing most of ours under general. We're actually 2 axes. If we're thinking PVI, we're actually skipped off the CS at this point, and it's just ICE and the Visigo, so 2 small axis points. So I think from a case standpoint, because it's a smaller French sheet too, makes it much easier. We're using vascular closure systems as well. I have to say, we're so spoiled in the US using all this technology, and then patients usually are going home in 2 to 3 hours. But it kind of helps the workflow, I have to say.
And Christian, one of the things that I notice is that when you come back out of the vein, you're obviously, because the vein's got an eccentric orifice, your catheter on the posterior wall is in contact. The one on the anterior wall is either inside the vein or not in contact. Do you select the electrodes to just treat the bits that are in contact, or do you just deliver on everything?
Yeah, so I mean, this question is more or less important when we come to the situation that we see an atrial tachycardia afterwards, and then we go to the anterior wall and need to do some treatment. there. In this case, we really deactivate. We try to use the catheter sheep to have just electrodes 1 to 5 into wall to tissue contact. So yes, sometimes we deactivate them. We also deactivate them when we are very sure that we ablate somewhere in the blood pool. Then we also deactivate them. Sometimes in this situation, we lost the osteal position, but we still had some contact with the carina area as far as there is a chance for that. This is why we kept them activated, but we always try to avoid, let's say, some ablation in the blood pool. Therefore, we indeed do activate these electrodes under certain circumstances.
And that brings me on to my follow-up, which is hemolysis. You know, there are some technologies that may be vulnerable to, if you give too much, that people can get hemolysis and renal problems. Do you limit how many applications you give? Are you conscious of that with this technology?
Yeah, so normally from the data we just have, let's say, 4 to 5 additional applications. So we try to do as less as necessary. But we never observed in our hospital these kinds of more than 100 lesions. So I think what we know from the literature that it starts with this problem maybe up when we have more than 70 lesions, which is also almost never the case for us. So staying with these, let's say 16, 20, 24 lesions, we have not observed it. But I'm quite sure it's possible that you do hemolysis when you perform this kind of what Philip Sommer always says, ablate like hell syndrome. When you follow this approach, saying I ablate everywhere, then you will get hemolysis and also other collateral damages. I'm quite sure.
Brilliant. Well, we're coming towards the final minutes. Perhaps I can ask Kousik to sum up where he sees this particular technology fit in with the other PFA technologies. Where does it fit into your practice?
I think it's an extraordinarily efficient tool for like a PAF patient because it's well suited for the veins, both kind of a belt and suspenders. You get the osteal lesions, the antral lesions, and those osteal lesions, I think, also really get the carinas quite well. So you hit the carina from both the upper and the lower veins. So I think you get very durable PVI. I think the fact that it's got TPI allows you to be very confident on contact without necessarily needing ice. Like in the United States, like putting ice in the left atrium gives you great images, but you wouldn't need to put ice in the left atrium with this system because you can utilize the system's ability for contact. And I think contact is very important both for efficacy and for safety to try to make, like Devi mentioned, every lesion count. You won't need to give extra lesions, which then decreases the risk of hemolysis, but also improves the chance of durability. So I think it's a extraordinarily efficient technology for paroxysmal AFib, and we have used it. We've done my partner and I, over 300 cases. We are using it routinely if we need to for the posterior wall and find that it's very efficient for that as well, off-label agreeably, but I think that we'll find that these technologies can eventually be proven to be safe in non-PVI areas. So that's my experience with the catheter.
And Devi, the contact's not so important for you because, of course, you use eyes so much and you're so good at looking at the electrode positions. How does this technology fit in with your PFA practice?
So I mean, I would say that I'm gonna use every adjunctive tool I have to assess contact, because remember, I mean, this is a 3-dimensional catheter, so you could be looking at 2D eyes. You're just looking at one plane, right? So to me, I don't have to keep rotating the eyes too much, move the eyes too much to assess contact. I'm using eyes to maneuver the catheter easily, not use fluoroscopy. That is really the main purpose for me to use eyes, but I still use the TPI. I mean, absolutely, to assess contact. ICE is more of, keeping up with any safety concerns, keeping up with maneuverability, etc. But having said that, I absolutely love the TPI aspect of it, so I don't have to keep verifying and move the ICE all the time. But I still use ICE in the LA. It's a habit.
And let me give you the last word,
Good.
Christian. Where does this fit into your practice in terms of comparison to other PFA technologies?
Yeah, so my final statement is good TPI means good lesion formation. It's a very important tool. We use it a lot. And we have, and this is maybe one of the unique things, we have MRI data for that, which is very promising. So once again, good TPI, good lesion formation. That's my final statement.
Well, I have to say that I'm pretty annoyed with you and your team because you've made me work very hard. You're so quick at the ablation. I've had to think of lots of questions and discussion points to fill in the time because the procedure was so quick. So you're all very naughty, but thank you so much for staying late and sharing this case with us. And of course, thanks to the patient as well, because I'm sure everyone's learned an enormous amount from their case. And so that brings us to the end of the session. And thanks to Christian and the team at Bad Oeynhausen. I've got a German name, but I can't pronounce German words. Very, very shameful. Thanks to our panel, Devi and Kousik. And we're going to take a short break in the plenary program. And next up, we have a symposium, AF Care Pathway in 2026, Optimizing Outcomes for Ablation and Stroke Prevention. So do stay with us, and we'll see you in a short while.
Thank you. Bye-bye.